Um, Good afternoon, everyone. I'm Chairman Lam. I'm an MBBS Year 4 student. Our project is application of self-supervised learning algorithms on retinal images of patients with diabetes mellitus to predict renal outcome. So diabetes mellitus means there's excess sweet urine. And the sweetness comes from hyperglycemia, which means there's too much glucose in the blood. This damages blood vessels and leads to various complications in diabetes. 1 in 10 people in Hong Kong have diabetes mellitus, and more than a third of them have diabetic kidney disease. Diabetes mellitus has become the 10th commonest cause of death in 2020. As you can see, there's an urgent need for early diagnosis and complication prevention. You might wonder, why do we want to use retinal images of the eye to predict kidney disease, right? Because the eyes and the kidneys are both microvascular structures under the influence of the renin, angiotensin, aldosterone system. Some of the receptors are the same, so they are affected similarly by diabetes. The main task that we did was to differentiate retinal images of patients who have kidney disease 1 year later from those who don't. So we did it through using artificial intelligence algorithms, AI that is. When we're talking about AI, you probably are thinking about sentient machines, etc. But no, we're not talking about that today. We're talking about machine learning, a subset of AI. These algorithms can learn from experience. According to Tom Mitchell, their performance at tasks improves with experience. And this is done by updating the parameters to optimize the loss function. And a subset of machine learning is deep learning. And among deep learning, there's convolutional neural network, CNN.
Hold on. I think I was doing something and that's not, oh my goodness.
Sorry, is someone...
I'm going to ask all people who are not presenting to mute, please.
Okay,
right?
Let's go on.
So convolution is the matrix multiplication between a part of the image as shown in the yellow boxes and a kernel as shown in the right upper corner. So this process extracts and preserves features of the images. And in real world application, we would have CNNs that are made up of layers after layers and blocks after blocks. So in the title, we talked about self-supervised learning. It allows the algorithms to learn feature representation of the images. So in this step, we made use of unlabeled images, which really saves time and energy and human resources for labeling them. And the specific task we did was simple contrastive learning. So we take a retinal image, augment them into two. By augmentation, we mean we crop them, rotate them, etc. And then we put them into a pre-trained ResNet 18 backbone. The goal we hope to achieve is that images from the same retinal photo attracts, while images from different retinal photo repel. So we did it by optimizing the loss function on similarity. Then we carry on with the downstream task. So in this step, we will use labeled images to fine-tune the ResNet 18. And for the output, we would have vectors with two variables, namely the probability of 0 and 1. We'll get to what that means in a minute. So for approach 1, where we only use retinal photos, we have already obtained the final probability at the last step. So we also did approach 2, where we will incorporate other data, age, albuminuria into it. Albuminuria means there's protein in the urine, and this signifies a deterioration in renal function. So for each retinal photo, we have a vector. We would incorporate the outputs from previous steps and plus age and albuminuria into it. And then we put these vectors into a logistic regression model to get the final probability of 0 and 1. So the baseline of the patients were obtained were around 2013 when their retinal images were taken. Their lab data were collected up till March 2020. So as you can see on the right, we had to exclude some images due to quality issue, some due to a lack of lab data. And we end up having 14,000 labeled images. We label them into zeros and ones. And what does that mean, right? So if a person have one eGFR, that is estimated glomerular filtration rate, below 60 units, around 1 year after the retinal images were taken, then the images of this person were labeled as case or 1, and the remaining will be labeled as controlled or 0. And for the 14,000 images, 80% were used in training. Among them, 20% were used in validation, which means we use that part to adjust the hyperparameters and to see how the generalization of the model is, and an independent 20% for testing. So these are the results. There's the receiver operating curve on the right. So for approach 1, where we use only retinal photos, we achieve 0.81 area under curve. For approach 2, where we incorporate other data, we achieve 0.85. So what does that mean? Let's take 0.85 as an example. So it means that it's 85% probable that a randomly chosen diseased individual is ranked with greater suspicion than a randomly chosen non-diseased individual. So in our project, this would be demonstrated as in the randomly chosen diseased individual having a higher score than the randomly chosen non-diseased individual. So from the table on the left, we were able to calculate the F1 score and Matthew correlation coefficient. F1 score is optimal at 1, and we achieve 0.7. Matthew correlation coefficient ranges from -1 to +1. So these show that the model has excellent classification ability. However, there is still a lot of room for improvement. So lastly, I'll talk about the limitations. The premise of this project is to use retinal images to predict kidney outcome. So we do acknowledge that there are so many factors that are not visible and they're not found in the retinal images. And these factors might be crucial to predict the kidney outcome of the patient. So if we had more features, more clinical features, we would be able to make the prediction more accurate. Secondly, diabetic eye and kidney disease may not be concurrent, which means the patient may have either one of them without the other. Thirdly, data insufficiency. So we also try to apply multi-instance contrastive learning. The only difference between this and simple instance contrastive learning is that for the very first step, we use 2 photos from each patient. So instead of using all 30,000 images, we can only use 6,000 for 30,000 patients. So even with that data insufficiency, we were able to achieve area under curve of 0.79. So we're confident that if we had more data, we will be able to further improve the performance of the model. Fourthly, we had no external validation data sets to verify our results. And last but not least, the black box problem. So we don't know how the algorithm arrived at its conclusion. We know the input, we know the output, we don't know how. So it might be difficult to gain trust in physicians and patients. So in the future, we would hope to develop explainable AIs and to obtain more data and to include more clinical features in the future. So these are the references. Thank you.